This is, I feel anyway, an important subgroup or post-hoc subgroup analysis, just post-hoc analysis of that clinical trial, because it's trying to provide some data on a very important clinical question. So in the study that was done, we noticed, and we're expecting to find, that there's significant anemia. This is an on-target effect of how Belzutifan works as a HIF-2 alpha inhibitor. And as a consequence of this profound anemia and rapid anemia that can occur for these patients, they become quite symptomatic. We have a lot of therapies and ways to try and address symptomatic anemia with erythropoietin-stimulating agents, with transfusions, et cetera, dose reductions. So there's a lot of strategies and mechanisms. In the original protocol, and indeed in other Belzutifan studies that were done outside of VHL, ESA use, erythropoietin-stimulating agents, ESA use was allowed per protocol. So this is something that was done in these studies. However, given some concerns more broadly in the oncology community that ESA use may attenuate the effect of oncologic therapies, in the package insert, it's not recommended to do ESA use. So it leads to this very difficult sort of clinical conundrum for many of us treating these patients, where we have experience through these clinical trials that it was done, but due to some of these theoretical concerns, the FDA was recommending against it. So this is a way, because we have collected this data, this is a way for us to try and provide some data on that subject in these patients specifically. So again, what we did with this post-hoc analysis is stratify the oncologic outcomes by ESA use. What were the median PFS? Well, there's a lot of different sort of disease manifestations and therefore outcomes that you can measure, whether it's hemangioblastomas or the RCC lesions. So for this analysis, we were focusing on the PFS of patients as measured by their renal tumors. So anyway, we stratified them based on ESA use or not. Again, it's a relatively small study to begin with, and once you stratify ESA use or not, the two cohorts are relatively small. But we did not see any meaningful difference in the median PFS between these two outcomes. We felt that this was the best disease manifestation to track because, first of all, it's a cancer, whereas the other disease manifestations are benign tumors. And this is also the disease manifestation where we were seeing some disease progression. So it allowed us to determine if there was an increased rate of progression or not with or without the use of ESAs.